Hi students, so the first topic for maternal and child 2 is about complications of pregnancy. A high-risk pregnancy is one in which a concurrent disorder, a pregnancy complication, or external factor jeopardizes the health of the mother, the fetus, or both. So here are some of the disorders or the common disorders that we will be discussing, which makes a pregnancy to be considered a high risk one. First is bleeding in pregnancy. Always remember that bleeding during pregnancy is a deviation from the normal. We recall that when a woman is pregnant, there is no continuation of the menstrual cycle because for menstrual cycle to be initiated, the woman needs to have the initiation of the hypothalamus via the negative feedback. And negative feedback is only stimulated if a woman's hormones are low. But if a woman is pregnant, you know very well that for pregnancy to be successful, that woman needs very high hormones. And with high hormones, there's no negative feedback. Without the negative feedback coming from the hypothalamus, the menstrual cycle will not proceed. Therefore, no bleeding will occur. Alright, so if there is any kind of bleeding, even small spots of bleeding during pregnancy, it is always considered a complication. Now, when a woman is pregnant and the woman complains of bleeding, the very first thing to ask is, when did the bleeding occur? What specific age of gestation did the bleeding occur? Because the AOG to determine the trimester will help you also determine the possible pregnancy concerns. Therefore, you would know how to manage properly right away. During the first trimester, if bleeding occurred, it's possibly a spontaneous miscarriage or ectopic pregnancy. If bleeding occurred during the second trimester, the possible conditions are H-mole or premature cervical dilatation. Third trimester, possibly placenta previa or abrupt placenta. That's why, again, it's important that when you have determined there is bleeding, the first thing to identify is the age of gestation, whether first, second, or third trimester. A woman with any degree of bleeding needs to be evaluated for significant blood loss, or we do not want hypovolemic shock to happen. Figure 21.1 shows how the process of shock occurs because of blood loss or hypovolemia. And when we assess a pregnant woman with hypovolemic shock, we have to check very well, of course, the skin color, the changes in level of consciousness, the cardiorespiratory condition, even the urinary output, and most especially the fetus. Signs occur when there is about 10% of blood loss or around 2 units of blood. Fetal distress is of utmost concern. Fetal distress usually happens if about 25% of blood loss already occurs. So, most important to know is the baseline blood pressure. And of course, let the mother know it as well. So, for the mother, always check the BP, that's the most important. And of course, to check fetal distress also, you have to check the fetal heart rate. Now, when there is bleeding in pregnancy, emergency interventions lead to stopping the bleeding. That's what you want to do. Stop it immediately because you want to conserve blood and prevent fetal distress. You have to alert the healthcare team of the situation that will provide maximum coordination of care. It's important to place the woman flat on bed or on her side, most probably or the best position, left side lying. That will maintain optimal placental perfusion, especially going to the baby. IV fluids can be initiated. Of course, that will replace fluid that is lost, or possibly the blood replacement might be needed as well. Oxygen can also be given, uh, possibly by face mask, 6 to 10 liters per minute. It will provide adequate fetal oxygenation to the baby via the mother. Also, it's important that you monitor the uterine contractions and fetal heart rate to assess whether is labor possible. So you know if the age of gestation is less than 37 weeks, that will be of primary concern. It's also important to prevent any kind of vaginal examination if possible. Why? Because the mother is bleeding, doing vaginal exam can cause further bleeding. It's also possible to withhold oral fluid because of the possibility of an emergency surgery. So, allow the mother to be on NPO. Anyway, you can hydrate the mother via the IV fluids. It's important to be ready also, have proper blood typing, no? Order the blood type, cross matching of possible fresh whole blood or packed RBC if the mother would need blood transfusion. Measure intake and output as well. This will enable uh, assessment of the kidney function. And again, it's important to always monitor via the intake through the IV and the output hourly. Important to assess the vital signs of the mother. It's a baseline data for blood loss. Also, possibly measuring central venous pressures, but this is of lesser concern when the bleeding is just starting. Important This is important because it will measure the maternal hemodynamic state, but only those who are about nearing the state of hypovolemic shock. Important also to measure maternal blood loss, weigh the pads, save any tissue. It will give us an objective evidence of the amount of bleeding. If a pad is saturated in less than an hour, it's an assessment or a qualitative assessment of heavy blood loss. Set aside a blood drawn IV in a clean test tube. Observe it in 5 minutes for clot formation because during normal pregnancy, we learned that clotting factors are normally high during pregnancy because that mother anticipates normal blood loss postpartum. So clotting factors are normally high. Checking this will now check for possible blood coagulation problems, which is another complication related to another complication. Assist with need for ultrasound exam to give us information about the fetus. It's more accurate. Of course, aside from checking the fetal heart rate, maintain a positive attitude, support the mother, and of course, that would include the self esteem, emotional support, and it is best if the best support person is there, which is the husband. It assists with problem solving by involving the mother, the family, and the husband in the plan of care. Now, as mentioned a while ago, bleeding in pregnancy may be because of several factors, and one of which is spontaneous miscarriage. This is possible if bleeding is within the first trimester of pregnancy. Abortion is actually the medical term for interruption of pregnancy. And when we say spontaneous, referred to as miscarriage, no, it is non-intentional. It is not induced. All right. So spontaneous interruption of a pregnancy before it reaches viability. And again, recalling the normal pregnancy, when you say viability, the fetus is not in a 20-week or more age, which is less than 20 weeks AOG. Again, spontaneous means the miscarriage occurred from natural causes. It was not induced. Now, what are the causes? It could be because of abnormal fetal formation during intrauterine life, abnormal implantation. The implantation should normally occur where? It should be in the upper posterior portion of the uterus. Any kind of trauma to the mother. The mother had an accident, for example. Any kind of infection, especially if these are reproductive infections or massive blood infections or sepsis. And lastly, it could be because the corpus luteum failed to produce enough progesterone or hormones. Again, recalling the normal, the corpus luteum is there to supply high hormones early in pregnancy. That is when there is no functioning placenta yet. And again, why do we need very high hormones? It makes the fetus or it makes the pregnancy possible. High hormones allows for proper formation of all the products of conception. There are several types of miscarriage or spontaneous abortion or spontaneous miscarriage. The first two, which is a threatened, imminent, or inevitable, please remember that bleeding occurred in the first trimester and upon checking, the fetus is still alive. In threatened and imminent or inevitable abortion, there is still fetal heart rate. Okay, but what's the difference? In threatened abortion, bleeding occurred in the first trimester, the fetus is still alive, but vaginal bleeding is the only symptom that occurred. There is no cervical dilatation, no other symptoms felt by the mother. When you ask the mother, did she feel uterine cramps? No. Did she feel any pain? No. There's just vaginal bleeding. What about imminent or inevitable? In imminent or inevitable abortion, the bleeding occurred in the first trimester of pregnancy. Second, when you check the fetus, there is still fetal heart rate. The fetus is still alive. But aside from the vaginal bleeding, uterine contractions occur, there is a cervical dilatation, there are uterine cramps, meaning there are other additional manifestations aside from the vaginal bleeding. Obviously, the goal here is to stop the bleeding immediately because you want to save the life of the fetus. Among the two, of course, obviously, imminent and inevitable or imminent inevitable abortion is more threatening. There is a higher risk or a higher chance that the pregnancy might be unsuccessful. It's also important that you maintain bed rest at this time because that will prevent further bleeding. Now, the next three types of miscarriage, complete, incomplete, and miss, these three means that, especially incomplete and incomplete, both there is bleeding in the first trimester, and when you check the fetus is already dead. There's no fetal heart rate. So incomplete abortion, the entire contents are expelled without assistance, which means lumabas yung fetus, lumabas yung umbilical cord, lumabas ang placenta, nothing is left inside the mother's uterus. You just have to monitor other contents that will be expelled, monitor the bleeding, there is complete expulsion of all the products of conception. While in incomplete abortion, a part of the conceptus is expelled, but some are retained in the uterus, meaning you have to do something so that all the contents will be expelled. And most probably, usually they do dilatation or curettage, DNC, or in Tagalog, raspa. Okay, that's why incomplete and incomplete abortion. So number 3 and number 4, these are cases where spontaneous miscarriage happens, bleeding happens, at the same time the fetus is already dead. In missed abortion, again, the fetus dies in utero but is not expelled. No? Meaning here, there is bleeding during the first trimester of pregnancy. When you check the fetus is already dead, but nothing has been expelled. In this case, you really need to remove all the products of conception. Sometimes, they also do dilatation and curettage or DNC, but sometimes they allow a normal spontaneous delivery, as if the mother had undergone vaginal delivery. But how will they do that? Of course, for vaginal delivery to be possible, there should be an effective uterine contraction. Paano magiging contracted ang matres? Maaring injectionan si mommy ng oxytocin. In that case, pag in-injectionan si mommy ng oxytocin, of course, magko-contract yung uterus, cervical dilatation, cervical effacement, mailalabas ni mommy yung fetus na parang natural lang. Yun nga lang, the fetus was expelled dead. Okay? So that's missed abortion. Now, there is possible term also called as recurrent pregnancy. When you say recurrent pregnancy, it's a loss of at least 2 spontaneous miscarriage happening at the same AOG. For example, first pregnancy, nagkaroon si mommy ng incomplete abortion at 16 weeks. After 2 years, nabuntis na naman siya, nagkaroon naman siya ng missed abortion in around 19 weeks. So, almost the same AOG. Recurrent, parang paulit-ulit. Sometimes, if there is recurrent pregnancy, the doctor has to check because there is a probably reason for having that kind of pregnancy na hindi siya nagiging successful. So again, threatened, imminent, first trimester bleeding, the baby is alive, complete, incomplete, missed, it's spontaneous miscarriage, bleeding, first trimester, but the baby is already dead. Okay, now, there are cases like this. It started as imminent abortion, eventually it will lead to missed abortion. May mga ganong cases, no? Minsan naman, it started as threatened abortion and then naging successful. Nabuhay naman, nabuo naman yung baby. But sometimes, no, threatened abortion, tas maya-maya, naging complete abortion. So there are those cases. It depends on many factors, especially how the healthcare providers will manage the bleeding with threatened or imminent inevitable abortion. Now, there is no cure to hold pregnancy, but estrogen in the form of DES, diethylstilbestrol, if you remember pharmacology, it's a teratogenic. Before it was used, although there is no conclusive evidence about it. Okay? Possible complications of spontaneous miscarriage is hemorrhage if you will not stop the bleeding, infection. It could be septic abortion, meaning there has been already a massive blood infection. There could be isoimmunization or the Rh incompatibility, which you are familiar with already. Or there could be powerlessness, anxiety because of the fear of the mother. Now, here are some of the interventions that you need to remember when there is spontaneous miscarriage. Save all tissue that has passed, because that can be used for reference or checking, especially in the laboratory. Keep client at rest, no strenuous activity, bed rest is important. Sometimes, may mga nanay nire-require for the entire pregnancy, I think you really need to be on bed rest. That sometimes they even have to stop working in order to save the pregnancy, because that will prevent, of course, further bleeding as well. Increase the fluids, either per orem or IV, to hydrate. Prepare the client for surgical intervention if needed. What are those surgical interventions? Possibly dilatation and curettage, or possibly also if there is some missed abortion, baka bigyan siya ng oxytocin para magkaroon siya ng contractions and then mag-undergo siya ng spontaneous vaginal delivery. Yun nga lang, patay na si baby. Also important, provide discharge teaching about limited activities and coitus after bleeding ceases. Nabuntis din naman yung babaeng ito. So remember, no, in the normal postpartum period, coitus can be resumed or can resume if there is no bleeding already, pag lochia alba na. So ganun din naman dito sa spontaneous miscarriage. Nabuntis din naman yung mother. Yun nga lang, shorter period. Provide emotional support. That's important. And you can give ROGAM if the mother is Rh negative to prevent isoimmunization. But anyway, we have a separate discussion for isoimmunization later on in the slide. The second possible cause or reason of bleeding during the first trimester of pregnancy is ectopic pregnancy. In ectopic pregnancy, the implantation occurs outside the uterine cavity. You know very well that implantation should occur on the upper posterior part of the uterus in order to make way for the growing fetus and the other products of conception. Mag-uumpisa muna siya as nag-proliferate yung maraming trophoblasts, nagkaroon ng chorionic villi, unti-unti na siyang gumagawa ng placenta, tapos si blastocyst, no? Specifically yung embryoblast, embryo hanggang maging fetus, siya yung pinakamatagal na tumubo. Okay? But in ectopic pregnancy, hindi sa uterus nagkaroon ng implantation. Ectopic pregnancy is an unsuccessful pregnancy because of what reason? It's because there is no room for growth. That's the reason why. That's the only reason why. Kaya hindi successful ang ectopic pregnancy kasi walang space para tumubo or mag-grow yung fetus o yung lahat ng products of conception. Because remember, the uterus extends so big. Lumalaki siya as big as a newborn. Kaya siya yung may capacity to hold the growing fetus and other products of conception. No other part of the body can expand as big as how the uterus can expand. Your intestines can expand, but it's not as big as the uterus. Our urinary bladder expands, but not as big as the uterus. Now, the most frequent site of ectopic pregnancy is in the fallopian tube. Again, the fallopian tube is where the tissue is starting to grow, and the very small fallopian tube is incapable of the growth needed to accommodate pregnancy. The uterine tubes or the fallopian tubes are very small, so rupture occurs usually even before 12 weeks, kaya first trimester siya. This is actually a medical emergency or an obstetric emergency. If somebody learns about ectopic pregnancy, the goal is to remove the pregnancy or to stop the pregnancy right away. Why? Because you do not want for the body part where implantation occurred, no, you do not want that body part to rupture. Because you cannot stop the product of conception from growing. Tuloy-tuloy siyang tutubo. So, kung tubo lang siya ng tubo, puputok, maaaring pumutok yung pinagtutubuan niya. So, si fallopian tube, habang tuloy-tuloy lumalaki yung product of conception, puputok siya. And rupture occurs. And that's another problem. Kasi pag pumutok yung fallopian tube, magkakaroon ng massive internal bleeding in the reproductive tract. So, as early as possible, you have to remove the ectopic pregnancy. That's the reason why ectopic pregnancy is bleeding in the first trimester. Kasi sa sobrang liit ng fallopian tube, which is the common site, no, doon maaaring mag-implant, maliit lang yung fallopian tube, so madali siyang dumugo kapag lumalaki na yung product of conception. Now, do not think that ectopic pregnancy only occurs in the first trimester. Kasi nandito siya sa first trimester bleeding. May mga ectopic pregnancy na determine na second trimester, minsan pa nga third trimester. Depende kasi yun kung nasaan nag-implant. There are cases nag-i-implant sa cervix, sa ovary, no, other body parts. In the photo, you can see in the intestine, no, and sometimes, if it can still accommodate the size of the growing tissue, lumalagpas ng first trimester yung bleeding, hindi agad na detect. Okay, syempre, ang definitive diagnosis dito is an ultrasound. Alright? Assessment findings. So, history of missed periods because still the mother is pregnant. There could be abdominal pain localized to one side, and that side is the usual site where implantation occurred. There's a rigid, tender abdomen or abnormal pelvic mass. That's where, again, the ectopic site is. Bleeding, especially if malapit na siyang mag-rupture. No? If severe, again, we do not want hypovolemic shock to happen. Low hemoglobin, hematocrit, and rising white blood cell. Sign of inflammation, no? And HCG titers are usually lower than in intrauterine pregnancy. If you recall the normal, ang unang-unang nagpo-proliferate sa uterus ay ang trophoblast. And of course, yung trophoblast, no, palaki ng palaki yung uterus, palaki ng palaki yung padami ng padami yung trophoblasts, and the trophoblasts are the ones producing the HCG. Kung sa fallopian tube lang magpo-proliferate ang trophoblasts, mas kaunti yung mapoproduce niya na HCG. Alright, but with a simple pregnancy test, we cannot really determine ectopic pregnancy with HCG alone. Kasi doon sa simpleng pregnancy test, ang dinedetermine lang naman doon if there is HCG or not. That's why you cannot determine ay ectopic ang pregnancy mo with a pregnancy test unless you bring it to laboratory and you really count the HCG. Okay, but if you just determine the presence of HCG, may HCG pa din doon sa ectopic pregnancy. Alright? So in this photo, you can see, right, ectopic pregnancy. Again, management here is immediate surgery. No, it will stop the bleeding and most importantly, it will prevent the rupture. Now, again, why is fallopian tube the usual site? Because the fallopian tube is the site of fertilization. And there are cases na after fertilization, no, there's a zygote, and then there's a morula, and then there's a blastocyst, no, dapat nagta-travel na siya going to the uterus. In this case, hindi pa siya nakatravel papuntang uterus, na-implant na siya. That's why fallopian tube ang most common site. The next is hydatidiform mole or H-mole. Sometimes it's also called gestational trophoblastic disease. Okay, so in H-mole, there is bleeding in pregnancy also, but when is the usual time of bleeding here? In the second trimester. In H-mole, there is abnormal proliferation and degeneration of the trophoblast villi. Okay, why does that happen? In a normal pregnancy, 1 egg is to 1 sperm. And when that happens, nagkakaroon ka ng normal na zygote, normal na morula, and normal na trophoblast. I mean, normal na blastocyst. And the blastocyst contains the trophoblast, outer fluid, embryoblast, inner fluid. That's the normal. Pero pag may H-mole, usually, there is only 1 egg and then nagkaroon ng problema doon sa sperm. Okay? Either 2 or more sperms. O kaya nung na-duplicate na siya para maging zygote, nag-iba din ang formation niya. Okay? That's why pag nangyari yun, meron pa rin namang zygote. Pero iba yung timpla niya. Meron pa ring morula, iba pa rin yung timpla niya. Meron pa ring blastocyst, pero iba pa din yung ingredients niya. Okay? The same ingredients, pero iba yung timpla. If the normal, for example, is 1 teaspoon of sperm, 1 teaspoon of egg. Ito, para ba siyang naging 2 tablespoons of sperm, 1 teaspoon of egg. The same ingredient pero nag-iba yung characteristics niya. Okay? Ang sabi, ang normal lang dapat 1 egg and 1 sperm. So, nung nagkaroon ka ng zygote pa rin, pero iba yung itsura. Nagkaroon ka ng morula, iba pa rin ang itsura. Nagkaroon ka ng blastocyst, iba pa rin ang itsura. So ngayon, bakit naging trophoblastic yung pangalan ng sakit? Kasi, again, remember, if it is already the blastocyst, ano ang parts ng blastocyst? You have the outer trophoblast and the inner embryoblast. Now, I will ask you, yung trophoblast, di ba siya ang future placenta, umbilical cord, chorion, amnion, etc. At yung loob, embryoblast, siya yung future baby. Pag kasi H-mole na iba yung timpla, iba yung pag-form, sobrang dami ng trophoblast. To a point na yung embryoblast, hindi na siya tumutubo. Sino ba yung embryoblast? Si baby. Kaya sa H-mole, the mother is still pregnant, but the fetus will not develop. Kasi si trophoblast yung sobrang dami na hindi na tumubo yung embryoblast. That's the reason why it's called gestational trophoblastic disease. Okay? Assessment findings. Uterus expands faster than normal. Bakit? Kasi nga grabing mag-proliferate ang trophoblast. Hindi naman niya kailangan mag-proliferate ng sobrang bilis. No? Dapat sabay lang sila ni embryoblast. High levels of HCG. Kabaliktaran ng ectopic pregnancy. Again, anong reason? Dito, sobrang dami ni trophoblast. And the trophoblast produces HCG. Comparing to ectopic pregnancy, ang baba naman ng HCG. Because in ectopic pregnancy, usual site fallopian tube, ang konti lang tuloy ng trophoblast, kaya ang konti lang rin ng HCG. Alright, but again, I will tell you, hindi malalaman sa pregnancy test kung H-mole siya. Kasi ano lang ba yung nade-determine ng pregnancy kit? Kung meron or walang HCG. Hindi nade-determine dun sa pregnancy kit na ipapatak mo yung ihi mo para malaman mong buntis ka. Hindi nakikita dun ang level. Ang nakikita lang kung meron or wala. Alright? Dark red to brownish vaginal bleeding after the 12th week. No? Kasi nga andito na yung pag-proliferate ng trophoblast. No fetal heart sounds or palpation of fetal parts. Bakit? Kasi puro trophoblast yung tumutubo. Sino ba yung inner mass na dapat ding tutubo? Si embryoblast, si fetus. So, nawawala siya. Kaya sa ultrasound, there is no fetal skeleton. Okay? Alright, this is a photo of an H-mole. You see here the trophoblast proliferation. Puro lang trophoblast ang tumubo. Nawala na yung formation ng embryoblast na naipit sa loob kaya hindi tumubo yung fetus. Alright? It's a clear fluid film. Para siyang mga grape-sized vesicles. Okay? Important, no? To do suction curettage to evacuate the mole. Okay? Monitor for choriocarcinoma. This is important, no, because there's abnormal proliferation. And cancer is an abnormal proliferation of any cell. That's why, pag na-evacuate na yung H-mole in a pregnant woman, it's important to monitor HCG for 12 months after the surgery. Posibleng positive pa rin siya after 3 weeks, pero after that, dapat hindi na. No? Importante yun so that pregnancy also will not be confused with a malignancy. Yun nga lang, posible kasi na magkaroon ng choriocarcinoma. Teach contraception use so that pregnancy is delayed for at least 1 year. Nabuntis pa rin naman yung mother dito. And teach also about future risks, no, sa mga future pregnancy. Remember that having an H-mole increases the risk of having another H-mole. Ngayon, merong prophylaxis and treatment for H-mole, and that is methotrexate. Please recall, it's a chemotherapy drug in pharmacology. Okay, it's a prophylaxis and treatment for H-mole. Sometimes, dinadagdagan ng dactinomycin. Again, pakirecall yan sa pharmacology. Yung dactinomycin naman, usually given for metastasis, no? Lalo na kapag nagkaroon talaga ng choriocarcinoma. The next bleeding in pregnancy is premature cervical dilatation. This is previously termed as incompetent cervix. It's a painless condition in which the cervix dilates prematurely. Therefore, it cannot hold a fetus until term. We have learned that the cervix should only dilate when the fetus is mature enough to cope with extrauterine life, and that is when the fetus reaches 37 to 42 weeks. Now, often the first symptom is vaginal discharge, and this commonly occurs approximately week 20 of pregnancy when the fetus is still too immature to survive. Now, it's really very difficult to explain the particular reason for having premature dilatation, but it's associated with increasing age, congenital development, especially of the cervix, endocrine factors, hormones, and any kind of trauma to the cervix. Although it may be diagnosed by an early ultrasound before symptoms occur, again, it is usually diagnosed only after the pregnancy is lost. Because of the loss of a child due to previous premature cervical dilatation, a surgical operation termed cervical cerclage can be performed to prevent this from happening again, especially in a second child. This is also called the McDonald or Shirodkar procedure, where purse string sutures are placed in the cervix via vaginal route. This is under regional anesthesia, and it strengthens the cervix and prevent it from dilating. In this procedure, the cerclage or the sutures are then removed at weeks 37 to 38 of pregnancy so that the fetus can be born vaginally. Placenta previa now is bleeding that usually begins by the third trimester of pregnancy. This is a condition wherein there is an abnormally low implantation of the placenta, meaning the placenta is implanted abnormally in the uterus. From the photos, you will see several degrees of placenta previa, which is low implantation, partial placenta previa, and total placenta previa. Looking at the photos, in photo A, the placenta does not really cover the cervical opening. Therefore, you would think that the baby can still pass through the vagina. The same with the photo in figure 21.6b. The placenta still does not totally cover the vaginal opening or the cervical opening. It just partially consumes part of the cervical opening. Unlike in the photo C, the placenta totally covers the cervical os. By this way or through this photo, you will realize that in photo C, very impossible yung vaginal birth. Therefore, cesarean section is considered. Likewise, in photo A and B, even if looking at the photo, it's possible for the fetus to exit the cervical opening, hindi pa rin delivery of choice ang vaginal delivery. Why? Because the implantation of the placenta is very low, and we all know that with vaginal delivery, the baby goes down. Therefore, the baby can actually occlude the placenta. Maiipit niya yung placenta habang nagle-labor siya o nagle-labor si mommy. And when that happens, deceleration will occur. And it's a late deceleration. Now, try to recall what late deceleration is. Yung late deceleration, nagkakaroon ng pagbaba ng fetal heart rate ni baby at the end of every contraction. And what is the reason for that? Placental insufficiency during labor. And why? Kasi si baby mismo, maaari niyang maipit yung placenta habang bumababa siya during labor or habang nagde-descend siya. Therefore, with all types of placenta previa, cesarean section is the delivery of choice to prevent fetal distress, to prevent late deceleration, because it could be a condition that will warrant problems or fetal distress to the fetus. Because routine ultrasounds are usually performed during pregnancy, most of placenta previa are diagnosed early before bleeding during the time that the third trimester occurs, no, before bleeding can occur. But many low-lying placentas detected on early ultrasounds migrate upward to a non-cervical position. So sometimes the condition is explained to a woman. No? Pag ganon, cautious sila to do interventions and prevent bleeding or further bleeding. Now, painless ang bleeding sa placenta previa. And the bleeding usually occurs after the 7th month, may be intermittent, gaseous, or continuous. But the uterus remains soft because there is no uterine contractions. Fetal heart rate is usually stable unless there is maternal shock. That is why hindi natin option ang vaginal delivery. Dahil magkakaroon ng fetal distress pag nagkaroon ng late deceleration. And again, yung definitive diagnosis is by ultrasound. Now, nursing interventions, the main goal is to make sure that the baby is okay. So, important to ensure complete bed rest. Sometimes, the woman is really cautious to avoid coitus, get adequate rest, because this will make sure that the bleeding will stop or the bleeding will be prevented. Though vaginal exam as much as possible, again, because bleeding may occur, make provisions for cesarean section delivery. Important also to continue monitoring the mother, especially the fetal heart rate. Ang placenta previa, basta't maalagaan ng maayos si mommy at si baby, maaaring maging successful ang pregnancy. Just make sure that proper interventions are set in place. The next is abrupt placenta. This is premature separation of the placenta that occurs after week 20 to 24 of pregnancy. Unlike in placenta previa, in a premature separation of the placenta appears to have been implanted correctly. Nasa upper posterior part naman siya ng uterus, but suddenly, it begins to separate and bleeding results. Now, this is an obstetric emergency. because we all know that when the fetus is still inside, oxygenation, nutrients, all come from the placenta. As long as the placenta is correctly attached from the uterus, doon din siya kumukuha ng supply going to the baby. So if the placenta suddenly detaches from the uterus, it is of very big concern. You cannot reattach an already detaching placenta. The assessment findings are there is painful vaginal bleeding. Important to differentiate it with a painless bleeding in placenta previa. Placenta previa and abrupt placenta are both third trimester bleedings. But again, difference, painless in placenta previa, painful in abrupt placenta. Second is a tender board-like uterus. Usually, the characteristic is a sharp, stabbing pain which is high in the uterus kasi nandoon nga yung nagde-detach na placenta. Of course, you would see here fetal bradycardia and late decelerations. There is a total absence of fetal heart tone if there is already complete abruption. That's why it requires an obstetric emergency. Ilalabas nyo si baby. Whether premature pa siya or better kung full term na, ang importante mailabas agad si baby kaisa hintayin na na-detach totally yung placenta na nandoon pa sa loob si baby. This is the most frequent cause of perinatal death. Unlike in placenta previa, maaaring hindi maka-experience ng late deceleration ang baby. Kasi nga, hindi mo naman hahayaan sa placenta previa na magkaroon ng labor. Kaya CS yung option doon. But here in abrupt placenta, nagkakaroon talaga ng labor kasi nag-uumpisang mag-detach ng complications or yung manifestations, I mean. Kasi nga nag-start ng mag-detach yung placenta from the endometrium or the decidua, I mean. And there is also a possibility of additional signs of shock, especially if there is already heavy bleeding. This premature separation of placenta may follow a rapid decrease in uterine volume. Especially, it occurs kapag merong sudden release ng amniotic fluid. So it's very, very important to always check and assess, most especially the fetus. With abrupt placenta, it's important to ensure bed rest. But a lateral, not a supine position is the best. Preferably left side lying position. This will prevent the vena cava pressure and therefore prevent added interference with the fetal circulation. Second is to check the maternal fetal vital signs frequently, as often as 5 to 15 minutes. Importante din, the mother can be given oxygen by mask to prevent fetal anoxia too. Third is to prepare IV infusions of fluid or blood. It's necessary that a large IV catheter is set in place for fluid replacement. As an additional, importante na wag nang mag-cause ng further injury sa already injured placenta. So as much as possible, no abdominal exam, no vaginal exam, no pelvic exam. You can also anticipate further problems. That's the worst. Anticipate coagulation problems, which is DIC, or disseminated intravascular coagulation, which is also further discussed later on. DIC is an acquired disorder of blood clotting, wherein fibrinogen levels fall below effective limits. And we all know that fibrinogen is important for clotting. So if there is a sudden drop in the fibrinogen, it will cause further bleeding. Now, we mentioned that in abrupt placenta, emergency surgery may be indicated. If with already DIC, the CS may pose a grave threat due to the hemorrhage during surgery and incision, no, pag tinahina. Why? Because of the further injury that will occur. Magkakaroon ng mas maraming bleeding, meron na ng DIC. With that, an IV administration of fibrinogen or a cryoprecipitate containing fibrinogen may be given. This may be given prior or concurrent with the surgery. And of course, important to provide emotional support. No, best support person is the husband. Any woman also who has a bleeding during pregnancy or before birth is more prone to infection. So marami siyang posible pang maging komplikasyon pa. So it's important also to closely monitor during the postpartum period. Hypertension in pregnancy or pregnancy-induced hypertension refers to a condition unique to pregnancy where vasospastic hypertension is accompanied by proteinuria and edema. With hypertension, there is vasospasm o pagsikip ng mga blood vessels. Kung ang isang tao ay may hypertension, mataas ang blood pressure niya. But this type of hypertension is unique to pregnancy because whenever pregnant women develop hypertension, nasasamahan siya ng proteinuria and edema na wala naman dun sa common hypertension. This is often seen after the 20th week. It may also appear in labor or up to 48 hours postpartum. What are the probable causes? Because of gradual loss of normal pregnancy-related resistance to angiotensin II. Now, what does that mean? The RAA mechanism, the renin-angiotensin 1 and angiotensin 2 mechanism, explains the pathophysiology of hypertension. No? And angiotensin 2 is important when it comes to vasodilating properties. But suddenly, nung nabuntis yung babaeng ito, tumaas yung hormones niya, naging resistant sa angiotensin 2. And because nawala yung vasodilating properties, nagkakaroon ng vasoconstriction. Therefore, pagbuntis lang siya nagiging hypertension. Okay? The second is decreased production of some vasodilating prostaglandins. Ang prostaglandins may vasodilating properties din. Pero sadyang nung nabuntis siya, nag-decrease yung vasodilating prostaglandin. Therefore, mas madami yung vasoconstricting properties. Kaya nagkakaroon lang ulit ng hypertension pagbuntis. That's why it's unique. And if you see the probable causes, nagkakaroon lang nito every time na nabubuntis. And the usual causes, tumataas kasi yung hormones pag pregnant. Kaya yung babae, kapag hindi na ulit siya buntis, kapag siya ay nanganak na, wala na ulit yung hypertension. That's why there is only hypertension during pregnancy, hence the pregnancy-induced hypertension. As mentioned a while ago, hypertension in pregnancy or in all other kinds of hypertension, vasospasm is the key. No, nagkaroon ng pagsikip ng blood vessels. Now, in effect, when it happens in pregnancy, hindi lang yung pagtaas ng BP ang nangyayari sa kanila. Nagkakaroon pa ng additional proteinuria and edema, which does not happen with other types of hypertension. This figure 21.8 explains the physiologic changes with pregnancy-induced hypertension. That's why it leads to increased blood pressure, decreased urine output and proteinuria, and edema. Okay? The increased blood perfusion is caused by vasospasm initially, nagkaroon ng vascular effects, vasoconstriction, therefore nagkaroon ng poor organ perfusion leading to high blood pressure. Next, because of vasospasm, nagkaroon ng kidney effects. Kulang ang blood supply na napupunta sa kidney. Because of that, nagkaroon ng decreased glomeruli filtration rate and increased permeability of glomeruli membranes. Dahil doon, hindi nagiging effective yung filtering mechanism ng glomeruli ng ating kidneys. And when the filtering mechanism fails, nagkakaroon ng increased serum blood urea, nitrogen, uric acid, and creatinine. And that causes decreased urine output and proteinuria. Ideally, wala dapat protein sa urine because the protein, it's a big particle that should not cross the glomeruli. But because of the vasospastic effects to the kidney, nagkakaroon nga ng ineffectivity doon sa pag-filter niya. Therefore, nagkakaroon ng proteinuria. And lastly, when protein is lost, fluid in the cell goes out. Yun yung interstitial effects. Nagkakaroon ng diffusion ng fluid from the bloodstream into the tissue, from in to out, therefore causing edema. But this kind of edema should be checked or assessed well. Why? Normal sa babaeng buntis ang magkaroon ng edema sa lower extremities. And that has been explained before because mas maraming nagagamit na protein ang buntis dahil sa growth and development ng fetus. Normal lang yon kapag sa lower extremities. Pero if the edema goes up, umabot ng kamay, umabot ng muka, naging generalized yung edema, that may be also a manifestation or a symptom associated with hypertension in pregnancy. This table will tell us the hypertension type, with pregnancy-induced hypertension. Gestational hypertension, ito yung mataas na BP, 140/90 or nag-elevate 30, systolic, 15 diastolic. Walang proteinuria, walang edema. But if there is already preeclampsia, nagkaroon na yan ng edema and proteinuria. Merong mild, merong severe. So you can check the differences with mild and severe preeclampsia. It's with hypertension, edema, and proteinuria. There is no moderate preeclampsia. On the other hand, eclampsia ang pinakadelikado sa lahat. Kasi sa eclampsia, nagkaroon na ng seizure or coma associated with preeclampsia. So yan ang pinakadelikado. Now, itong hypertension in pregnancy na ito, as mentioned, nagkakaroon lang ng hypertension yung buntis pag buntis siya, Pero pag wala siyang pregnancy-induced hypertension. What about those women diagnosed with hypertension talaga? Sila pa rin ba ay at risk during pregnancy? Of course, yes. Pero hindi ganito yung hypertension type nila. Yung sa kanila, talagang chronic hypertensive disease. Alright? Kasi hindi pa man sila buntis, talagang diagnosed na sila with hypertension. The interventions for pregnancy-induced hypertension are the following. Now, the main goal here is if you diagnose hypertension in pregnancy, it's simple. You just give antihypertensive drugs. But the important is make sure those drugs are not harmful to the fetus. With preeclampsia, may tatlong problem. Ano yon? Hypertension, edema, proteinuria. Therefore, you can treat the hypertension with antihypertensive drugs, the proteinuria, and the edema. Iti-treat mo yon. But the main goal or the most important goal kapag may preeclampsia ang isang pasyente is for this patient to not develop eclampsia. Yun ang pinaka-importante. Okay? Because with eclampsia, napakadelikado na nun for the mother and the baby. So that's the most important goal. Okay? With eclampsia, nagkaroon na kasi ng seizures and convulsions. Okay? So, number 1 is promote bed rest. Again, lateral recumbent is the best. Sodium is excreted faster and it promotes diuresis. And also, this avoids uterine pressure on the vena cava at nape-prevent yung supine hypotension syndrome. Second, monitor maternal well-being, yung blood pressure ng nanay, importante. Ano ba ang gamot? Safe is hydralazine. Again, you have to review your pharmacology. Important then to give a platelet with low-dose aspirin, usually at 50 to 150 milligrams. Para saan ba ang aspirin? It's an anti-platelet drug para ma-prevent yung pagkakaroon ng clotting, pagkakaroon ng further risk of having DIC. Okay? And monitor the fetal well-being. So, ang nanay na may ganito, dapat chine-check. You have to review doing the non-stress test. Ano bang chine-check sa non-stress test? And ano yung mga chine-check sa biophysical profile. So, you have to review about that. Fourth, I mentioned kanina, ito ang goal natin kapag ang pasyente ay may preeclampsia, whether mild or severe, because we do not want seizures or convulsions to happen. So aside from giving BP drugs, maaari silang bigyan ng magnesium sulfate. This is a safe drug during pregnancy. Okay? Magnesium sulfate prevents seizures and convulsions. Okay? It is given deep IM, and magnesium sulfate is an anti-seizure drug. So, pwede siyang mag-cause ng neuromuscular relaxation. And because of that, importante na chine-check lagi before and after giving mag sulfate deep IM, maaari siyang ibigay sa buttocks area. So, importante na yung patient chine-check yung mga reflexes, especially the deep tendon reflexes. May pakiramdam pa ba yung patient sa lower extremities niya? So, you have to check neuromuscular tests. You have to do that. Okay? Diazepam can halt. Okay? It can stop when there is an attack. Importante ngayon ang antidote for mag sulfate. Magnesium sulfate, the antidote is calcium gluconate. So, dapat readily available siya. And how do you know if you need the antidote already? Kung wala na yung kanyang deep tendon reflexes. Okay? Promote good nutrition. Do not restrict sodium. Pero ibigay siya sa tamang nararapat lang na amount. Little amount. It can trigger RAA mechanism and cause hypertension. Okay? Important to promote emotional support, yung well-being ni mother at ni fetus, and again, baka magkaroon ng possible emergency CS, So, importante yung pag-prepare ng airway, oxygen, suction machine. Ngayon, for the proteinuria, of course, and the edema, mare-resolve yun eventually if unti-unti nating nire-resolve yung hypertension. Pero dun sa proteinuria, importante syempre na bigyan siya ng mga protein-rich foods. Doon naman sa edema, pwedeng bigyan ng diuretic, Pero, again, mawawala lahat yon kung unti-unti na mare-resolve yung hypertension itself. Okay? Hydramnios or polyhydramnios in this sense is excessive amniotic fluid formation more than 2 liters or an amniotic fluid index above 24 cm. We mentioned in the normal pregnancy that the normal or the average amount of amniotic fluid at term is 800 ml to 1,200 ml or halos 1 litro. No? Sa polyhydramnios, sobrang dami ng amniotic fluid na nagsusurround sa fetus. How many? Halos umabot na siya ng doble or 2 liters. Gaano siya kadami na nagkukos na siya ng harm doon sa fetus. Now, ano ba yung mga causes? Minsan, may mga cases na yung fetus, meron kasi siyang gastrointestinal abnormalities. One is esophageal atresia, meaning yung esophagus sarado. We know that the amniotic fluid is being swallowed by the baby. Kaya yung sinasabi natin na nagsusurround sa fetus na halos 1 litro, bawas na doon yung nalulunok niya. Pero kung meron siyang esophageal atresia, sarado yung esophagus niya, walang nalulunok yung fetus. Kaya, madami masyado yung nagsusurround sa kanya na amniotic fluid. Meron namang isang case, no, tracheoesophageal fistula or TEF. Ito naman, trachea from the respiratory system, esophagus from the gastrointestinal system. May fistula, may connection sila pero with stenosis. May pagsikip. Okay, sa ganon, hindi rin nagkakaroon ng ability to swallow yung fetus. Ganon din kapag may intestinal obstruction. So all of these are conditions that warrants inability of the fetus to swallow the normal amniotic fluid. Kaya ang dami-daming amniotic fluid outside. Another cause is because of excessive urine production ni baby. Maari din yon. Ano kaya ang posibleng dahilan? Malamang may diabetic mother. Okay, which we will further discuss later. Assessment findings, so mabilis lumaki yung uterus ni mommy, increase weight gain kasi nga ang daming amniotic fluid. Parts of the uterus are difficult to palpate kasi nga ang daming amniotic fluid na nagsusurround kay baby, as well as auscultating the fetal heart rate. And kay mommy naman, could be having shortness of breath, lower extremity varicosities, and hemorrhoids kasi nga masyadong lumalaki yung kanyang uterus. When there is polyhydramnios, complications may occur. One is malpresentation. No? Why? Because the additional space will allow the fetus to turn to transverse lie. Kasi nga, ang dami ng amniotic fluid na nilalangoyan niya. At kapag naging transverse lie, one problem is, ECCS siya for sure. Second is premature rupture of membrane. Reason is because of increased pressure because of prostaglandin release dahil ang amniotic fluid ay nagkakos ng prostaglandin or secrete or nagre-release ng prostaglandin. And then, meron pang additional infection dahil nga maagang pumutok ang panubigan. Ang panubigan dapat pumuputok during the active stage of the first stage of labor. Meaning, sa active stage, dapat ilang cm dilated na ba yung cervix, no? Pero may mga cases na 1 cm dilated pa lang, pumutok na agad yung panubigan. So, masyadong maaga. Kaya pwede magkaroon pa ng additional infection. Tapos, magkaroon ng prolapse umbilical cord. Yung pusod ni baby, inuunahan niya sa paglabas si baby. At kapag may prolapse umbilical cord, naipit ni baby yun, magkakaroon ng variable deceleration, another obstetric emergency. And also possible preterm birth. Kasi nga, ang laki na nung uterus. No? Remember, when an organ is full, it will empty. yung uterine stretch theory. As a management, importante ang bed rest sa polyhydramnios. This will again increase ureteroplacental circulation and reduce yung pressure sa cervix. Second is teach the mother to report rupture membranes or uterine contractions para hindi nga magkaroon ng mga posibleng komplikasyon. Maaari ding mag-umpisa ng NSAIDs or anti-inflammatory drugs, no? This will reduce inflammation, lalo na this will prevent preterm birth. Also, importante din na mag-perform ng amniocentesis as needed. Dito, ini-evacuate yung sobrang daming amniotic fluid. It could be repeated almost daily, lalo na kapag talagang may problema sa pag-produce ng amniotic fluid yung product of conception. No? Marami siyang produce ng amniotic fluid. So, kapag in-evacuate yon, baka magpo-produce lang siya ulit ng marami. So, that's why it can be repeated almost daily. Oligohydramnios is the opposite of polyhydramnios. Dito naman, there is insufficient amniotic fluid formation. Sobrang konti niya, halos kalahating litro lang, less than 500 ml. That's why this is also at risk kasi ano ba ang mga significance ng amniotic fluid, no? It can nourish the fetus, no? Nandiyan yung prostaglandins to initiate also uterine contractions. What are the causes? Baka may bladder or renal disorder si fetus that interferes with voiding, kaya ang konti lang rin ang ihi niya, and again, yung amniotic fluid o yung fluid, may kasama talaga siyang urine. Or dahil may severe growth restriction din, no? Because the fetus is cramped in space, muscles are left weak at birth, and lungs fail to develop. Kaya minsan ang mga baby, no, pag pinanganak due to oligohydramnios, they have severe difficulty of breathing after birth, and sometimes their facial features become distorted. Now, suspected in pregnancy, when uterus fails to meet expected growth. Kasi kasama yung amniotic fluid sa paglaki ng uterus, especially when we check the fundic height. Now, meron naman tayong tinatawag na amniotransfusion or instillation of fluid. This is by the uterus, no, through amniocentesis. This can help relieve this concern. Pero ginagawa ito kapag talagang sobrang kaunti nung amniotic fluid which already harms the fetus. Here's another photo of oligohydramnios. In this case, no, yung baby, bukod sa pagkakaroon ng oligohydramnios, nagkakaroon din sila ng other congenital anomalies, multiple congenital anomalies. As you can see, no, isa lang yung lower extremity ni baby, nagdikit both yung right and left lower extremity niya. And sometimes, pag may MCA or multiple congenital anomaly, hindi lang physical, no, na characteristics yung nakikita mo or physical abnormality, meron din minsan silang mga cardiovascular problems, no, respiratory problems, and the like. Next is isoimmunization or Rh incompatibility. Nangyayari lang ito if the mommy is negative and the baby is positive. Saan nakuha ni baby yung positive antigen, D antigen, coming from the father. Now, because the mommy has no D antigen, pag na-detect niya yan, posible na mag-produce siya ng antibody against it. At kailan niya madedetect yan? Kapag nagkaroon na ng bleeding. Usually, may bleeding upon birth. And when that comes, nakalabas na yung fetus bago pa man madetect yan ni mommy. Ang usually affected ngayon are the subsequent pregnancies. No? When the mother detects them, this stimulates the mother's immune system to produce the anti-Rh. Kasi nga, hindi naman siya familiar with the D antigen. So, i-attack niya yon and can cause hemolysis. Therefore, subsequent pregnancies are affected. Now, most are not formed during pregnancy, but again, as what I've said, matatapos ang pag-produce niya ng antibody in the first 72 hours after birth. And when the time comes na nabuntis ulit yung mommy, nandoon na yung antibody. Paano kung D-antigen din, no? Meron din si baby ng D-antigen. So, positive siya. Nandoon na sa tiyan ng mommy yung mga antibody. So, i-attack ng antibody na yon yung fetal RBCs, mamamatay yung fetus. Hindi magiging successful ang subsequent pregnancies. Okay, now, I mentioned that this is usually affecting the second or subsequent pregnancies. Pero may mga cases that Rh isoimmunization can also affect the first baby. Why? When bleeding happens during pregnancy. At sa mga previous na pag-aralan natin, maraming mga bleeding complications during pregnancy. So pag nangyari yon, madidetect ni mommy na nagkaroon na meron siyang detect na D-antigen. So baka nasa loob pa ng tiyan, even the first baby, mag-produce na siya ng antibodies against it. So ano ba yung mga bleeding complications na na-discuss natin? So possible pag first pregnancy, no? First trimester, yung threatened or imminent inevitable abortion. No? Kapag second trimester or third trimester, no, baka nagkaroon ng yung placenta previa, no? So, with those, pwedeng ma-detect ni mommy kasi bleeding siya, even first pregnancy yon, baka mag-produce na agad siya ng mga antibodies na harmful na for the baby. Kaya importante sa mga mommy na buntis na Rh negative ang mag-Coombs test. Hindi kinu-Coombs test kung buntis ka at Rh positive ka. The Coombs test tests for antibodies against the D antigen, against Rh. At kung Rh positive ka, hindi ka gagawa ng antibody. So, hindi ka i-Coombs test, no? Only the Rh negative mothers yung kinu-Coombs test. Indirect, if it is performed through the mother, direct naman kay fetus mismo. Now, the first photo above is ROGAM. It's the Rh or the D immune globulin. Isa siyang passive antibody at 27 weeks AOG and within 72 hours postpartum siya ina-administer. Okay? Ngayon, pag may ganito, no, mape-prevent na mag-produce si mommy ng antibody against the D antigen kasi passive antibody na siya. Okay? At hindi harmful to the baby. So again, it can be given 27 weeks AOG and within 72 hours postpartum. Another management is through intrauterine transfusion, the second photo below. No, ini-inject mismo yung RBCs through amniocentesis via umbilical vein as shown in the photo. Lalo na kapag meron ng hemolysis na nangyayari doon sa first pregnancy, for example. So, kailangan ng intrauterine transfusion. Another complication is hyperemesis gravidarum. This is excessive nausea and vomiting in pregnancy, which leads to dehydration and electrolyte imbalances, especially acidosis. Ngayon, sabi natin, morning sickness talagang nagsusuka. No? Minsan may mga babaeng buntis nagsusuka sa first trimester. But if the nausea and vomiting exceeds the normal, the threat here is dehydration or electrolyte imbalances. Cause is possibly a severe reaction to HCG. HCG is a not so familiar hormone to women na tumataas, unang tumataas yan pag buntis, no? peak is around 6 week and usually declines by the 12th week. Pero kung again, sobra-sobra siya o lumagpas pa doon, no, doon nadadiagnose ang hyperemesis gravidarum. And the management, of course, is towards preventing dehydration and electrolyte imbalances. Because the goal is preventing fluid and electrolyte imbalances, kailangan dinadala sa hospital si mommy kasi ENPO siya at kailangan ng IV fluid with electrolyte replacement. It's also important to monitor intake and output, provide mouth care. Minsan, kaya pala nagsusuka kasi maasim yung panlasa. No? Important ang mouth care. Unti-unti, reintroduce per orem. And importante din no, na may TPN and central line kung talagang mahabaan na. No? Really unable to eat si mother. TPN is total parenteral nutrition. Hindi lang siya basta IV fluids, no? Kumpleto yung nutrition through the IV. Ngayon, sa central line siya ikinakabit kasi kapag TPN, dahil nga mas kumpleto yung fluid na yon with nutrients, medyo malapot siya. Kaya kung peripheral line lang siya ikakabit, maliliit yung ugat at malapot yung fluid, no, baka magbara. Central lines or big lines. Yun nga lang, mas invasive siya, no, kapag central lines, pero best siya kung long term, yung IV fluid therapy. And lastly, important to offer emotional support also. Cardiac conditions in pregnancy may be the result of either congenital heart disease or sequela of rheumatic fever. When you say congenital heart disease, pinanganak yung babae na talagang may sakit siya sa puso. Or kung acquired naman, no, like rheumatic fever, nagkaroon siya ng heart condition after birth. Well, if a woman becomes pregnant and this woman has a cardiac condition, definitely the pregnancy will affect the woman. Mas delikado sa babae kaysa dun sa fetus yung pagbubuntis niya. Cardiac conditions in pregnancy may affect the pregnancy, but the woman is definitely affected by the pregnancy. Okay? The danger here is because the pregnancy in a woman with cardiac disease causes increase in circulatory volume. And may sakit nga siya sa puso eh. So, originally, hirap na yung puso niya. Pero, kailangan niyang mag-compensate with the increased circulatory volume. As what we remember, normal sa babaeng buntis ang nag-i-increase ang blood volume ng 30 to 50% because that blood is also intended for the growing fetus. The most dangerous time is about peak 28 to 32 kasi dito nagpipeak yung blood volume. At dito rin dapat magkaroon ng peak doon sa increased heart action. This is a team approach, no, when being cared for. However, no, if the heart disease is severe, symptoms can actually occur as early as the beginning of pregnancy kapag talagang malala yung kanyang heart condition. Kaya delikado sa babaeng buntis. A woman's heart may become so overwhelmed by the increase in the blood volume, especially toward the end of the pregnancy. Kasi dito mas malapit na siyang manganak, no? Her cardiac output falls to the point that the vital organs, including the placenta, which supplies the fetus, are no longer perfused adequately. Why? Kasi very overwhelmed na si heart. When this happens, neither the oxygen nor nutritional requirements of her cells or those of the fetus can be met. So here, we can see in table 20.2 the different classifications of heart disease. Class 1, uncompromised. Class 2, slightly compromised. Class 3, markedly compromised. Class 4, severely compromised. Yung Class 1 and Class 2, maaaring magkaroon ng normal pregnancy, normal birth. Si Class 3, nagre-require yan ng complete bed rest. No? Pero si Class 4, pag ganyan ang heart disease ni mommy, they are taught to avoid pregnancy. Kasi delikado talaga for these women. Let us now discuss different assessment findings, interventions for prenatal, intrapartal, and postnatal period when a woman with a heart condition is pregnant. In the prenatal period, check for evidences of cardiac decompensation, again, especially kapag nagpipeak yung pag-increase ng blood volume level at 28 to 32 weeks AOG. Pag may cough and dyspnea na, so nagkakaroon na ng respiratory compromise, edema, ibig sabihin hindi na makapump effectively si heart, nagkakaroon na rin ng heart murmurs, palpitations, and growls. With this, kailangan promote frequent rest period para hindi nahihirapan lalo yung circulatory system. Teach the mother about signs and symptoms of infection kasi kung magkakaroon pa ng infection, mas mahihirapan ang heart. Importante din i-monitor ang vital signs, including the fetal heart rate. It's also important here to limit weight gain of the mother. We remember again, during normal pregnancy, normal weight gain is 25 to 35 pounds, except if a woman has a heart condition. Kung lesser ang kanyang weight gain, which is limited to 15 pounds, hindi mas mahihirapan yung heart, to supply added action para doon sa growing fetus. And importante din na magkaroon ng anticoagulant therapy if needed because of the risk also of DIC or disseminated intravascular coagulation. During the intrapartal period, remember that labor increases the risk of CHF. Pag sinabing CHF, congestive heart failure, there is already an inability of the heart to pump blood effectively. Milking effect of contractions and delivery increases blood volume to the heart. So, mas nahihirapan yung puso. Kaya nagkakaroon ng heart failure, hindi na ganun kagaling mag-pump at nagkakaroon ng congestion yung puso kasi may pumapasok sa kanya pero hindi na niya ma-pump ng maayos. Nursing interventions, again, importanteng i-monitor si mommy and si fetus. Second, bakit mas prefer pa rin ang vaginal delivery kesa CS? Kasi pag may sakit sa puso yung babae at nag-undergo pa siya ng C-section, mas mahirap sa kanya yung general surgery. It's a major operation, lalo na yung healing process paggaling. Kaya vaginal delivery pa rin ang preferred because less effort pa rin ito for the heart compared to a major surgery. Kaya nga, nilimit lang sa 15 pounds yung weight gain para hindi mahirapan during labor kasi preferred pa rin ang vaginal delivery. Monitor stress of labor, administer oxygen, pain meds para less effort for the heart, choose the best position that will allow best circulation, calm atmosphere, relax, and of course, yung number 7 is somehow very difficult to teach, open glottis pushing. Meaning, yung pag-ire ng nanay during labor ay dapat meron pa ring extra effort, okay pa din yung breathing pattern niya. Or sometimes, ginagamitan ng forceps or vacuum extraction para mas mabilis ang paglabas ng baby from outside. During the postpartum period, it's very important to monitor very closely both the mother and the baby. Again, promote bed rest so that the heart can easily go back to how it was supposed to be, no? And have a stability sa function ng cardiovascular system. Assist with ADLs, no? Put little effort in everything the mother does para less yung kanyang uh, demands, no? Especially the metabolic demands. Prevent infection. Kung may sugat sa puwerta ang mommy, no? Always make sure that there is no added burden to the heart. Facilitate non-stressful mother and baby interaction. Importante pa rin ang bonding nilang dalawa. And also when the mother goes home, help the mother plan for rest activities at home na hindi pa rin makakompromise yung kanyang heart. Next complication is gestational diabetes mellitus. It's a chronic disease caused by improper metabolic interaction of carbohydrates, fats, proteins, and insulin during pregnancy. Again, just similar to the pregnancy-induced hypertension, pagbuntis lang si mommy nagkakaroon ng diabetes mellitus, meaning nagiging resistant yung katawan niya sa insulin, mainly because of very high hormones. So, yung interaction ng estrogen, progesterone, human placenta lactogen, and even cortisol, no? Nagkakaroon ng resistance si mommy dun sa insulin na pinoproduce ng pancreas. Hindi nagkakaroon ng problema yung mismong pancreas. Unlike in the usual diabetes, it's the pancreas. Yun yung may problem, either no secretion of insulin or less secretion of insulin. But in diabetes mellitus na gestational, okay pa rin si pancreas sa pag-produce ng insulin. It's just that resistant si mommy doon kasi ang taas ng hormones niya because she is pregnant. Box 20.7 shows us how to assess a pregnant woman with diabetes mellitus. It's important that if a woman has GDM, nakokontrol yung kanyang glucose level. If glucose is uncontrolled early in pregnancy, the high glucose will cross the placenta at magkakaroon ng fetal anomalies. And then, kapag nasanay na yung fetus sa sobrang taas din ng glucose early in pregnancy, paglabas niya as a neonate, very high risk naman siya for hypoglycemia. If glucose naman is very high late in pregnancy, again, glucose crosses placenta. Here, fetal insulin metabolizes it, and the excess glucose now acts as the growth hormone. That's why it promotes macrosomia or big babies. Kaya malalaki yung mga baby na ipinapanganak from mother with GDM. The following are risk factors for having gestational DM. It's obesity, mother age over 25 years, may previous history ng large babies, usually 10 pounds or more, nagkaroon ng history of unexplained fetal or perinatal loss, congenital anomalies in previous pregnancies, mother has PCOS, may history of diabetes mismo, one close relative or two distant ones, not necessarily na si mommy yung may diabetes. And lastly, population groups such as Native Americans, Hispanics, and Asians are at risk for having GDM. Now, again, ang GDM, nabubuntis lang yung nagkakaroon lang ng DM si mommy during pregnancy, like the one in pregnancy-induced hypertension. Pero if the mother already has diabetes mellitus prior to pregnancy, that's the usual DM or yung chronic diabetes mellitus. For the assessment, A fasting plasma glucose of 126 milligrams per deciliter above. When we say fasting blood glucose, it's usually after an overnight fast or at least 8 hours. Or a non-fasting plasma glucose of 200 milligrams per deciliter or more or above meets the threshold for the diagnosis of diabetes, and it needs to be confirmed on the subsequent day. So, paano siya ginagawa? Uumpisahan with a 50-gram oral glucose challenge test. So, binibigyan ng glucose load. Then, a venous blood sample, not arterial. It is taken to determine glucose level in 60 minutes. If the glucose level at 1 hour is more than 140, the woman will now be scheduled for another 100-gram test. And then, kukunin naman yung 3-hour fasting glucose tolerance test. Table 20.4 shows us the values from the test type, and if 2 of the 4 blood samples collected are abnormal or the fasting value is above 95, a diagnosis of diabetes is made. With any kind of diabetes, tatlo yung best na kombinasyon ng management for GTM. It's insulin, diet, and regular exercise. The best insulin control program for pregnancy must be determined. Importanteng minimeasure ang glycosylated hemoglobin because it can help detect the degree of hyperglycemia present. Glycosylated hemoglobin test is the most accurate kasi na-measure niya yung average glucose level in about matter of 3 months. Now, a fasting blood glucose level below 95 to 100 milligrams per deciliter and a 2-hour postprandial level below 120. These are well-adjusted values. We will not anymore discuss here the different types of insulin, but please review pharmacology, the insulin drugs. They are the ones given for GDM. Remember also that it should be insulin administration and not oral hypoglycemic drugs. Second is dietary control. Maintain adequate glucose intake so that hypoglycemia will not occur. This may be difficult early in pregnancy kasi maaring may morning sickness, It's important to reduce saturated fats and cholesterol, increase fiber, as these decreases postprandial hyperglycemia, and so it lowers the insulin requirements as well. Regular exercise, the blood glucose level decreases because the muscles increases their need for glucose. Ang effect nito, at least 12 hours lang after exercise. Therefore, exercise must be consistent from day to day. Infections in pregnancy must be treated right away, and they must be managed carefully to prevent risks for the fetus. One is a UTI, second is torch, and third are HIV infections. 10% of pregnant women may have UTI. It's a dilated, flaccid, and displaced ureters. Yun yung most frequent site. And usually, the E. coli is the common cause. If this happens during pregnancy, it can cause premature labor if severe. And kung untreated naman, baka magkaroon ng kidney problem kay mommy even right after birth. Assessment findings: frequency and urgency of urination, suprapubic pain, flank pain if it is already the kidney that's involved, could have hematuria, pyuria, and even fever and chills. For the nursing interventions, it's important for a mother to take high fluid intake, lalo na kung meron siyang lagnat. Provide warm baths to relieve discomfort and promote perineal hygiene as well. Now, this is very important to give antibiotics, but only antibiotics to treat the bacterial infection and are generally safe. And what are those? Amoxicillin, erythromycin, penicillin, cephalosporins, and clindamycins. They are all generally safe. Sometimes, no, may mga gamot din na associated with birth defects. So, dapat iniiwas natin na ibigay ang mga antibiotic na ito, and those are nitrofurantoin and trimethoprim sulfamethoxazole. Now, ano yung mga antibiotics na dapat iiwas if there is UTI in pregnancy? Do not use ciprofloxacin, sulfonamides, and tetracycline. So take note only of drugs that are safe during pregnancy. So please recall the different pregnancy category drugs. Important also to stress good bladder emptying schedule. We know ang mga buntis, mas madalas silang umiihi dahil tumaas yung blood volume nila. Pangalawa, yung pressure dun sa bladder. Huwag pipigilang umihi because stasis of urine in the bladder will favor the growth of E. coli, therefore cause UTI. And lastly, teach mothers about signs of premature labor. If there is infection, premature labor is the most common complication that can happen because with any kind of infection, there's inflammation. And inflammation can always stimulate uterine contractions, lalo na kung hindi pa kabuanan or hindi pa naman term. Torch infections involve toxoplasmosis, other infections such as hepatitis B, syphilis, group B, beta strep, rubella, cytomegalovirus, or the herpes simplex virus. Majority, these are viruses, and the best way is to prevent this from being acquired during pregnancy. Why? Because it's usually a vertically transmitted infection. Nagkukos ito ng malalang komplikasyon sa fetus, which is possibly abortion, malformation, and fetal death. HIV in pregnancy is the transmission of the virus, the HIV, through blood, semen, vaginal secretions, and even breast milk. Now, pregnancy, while there is HIV, will have several problems also to the fetus. And the good thing is HIV may not cross the placenta. Sometimes there are cases wherein mothers with HIV have an HIV-free baby when they are born. There are antiviral drugs such as zidovudine and azidothymidine, which decreases risk of transmission of the virus to the fetus. They help decrease the risk, but they do not necessarily remove the risk of transmission to the baby. Pregnancy on HIV infection, the mother is slightly immunosuppressive, and it doesn't usually cause morbidity or mortality to the mother. But the HIV infection on pregnancy will increase the risk of preterm birth, will increase the risk of intrauterine growth retardation, premature rupture of membrane, and infection. So definitely, mas delikado for the baby yung pagkakaroon ng HIV infection ni mommy. Adolescent pregnancy or teenage pregnancy is a high-risk pregnancy, mainly because pregnancy is both a condition of physical and psychological task. First, physical task. Yung katawan ng baby ay nag-grow sa loob ng tiyan ng nanay. At the same time, an adolescent child is still a pediatric child that is growing. So literally, para kayong sabay nag-grow at nagde-develop yung mommy at saka yung baby. That is why nag-aagawan sila sa nutrition, and there are lots of nutritional problems associated with it. And second is a psychologic task based on the different developmental theories. An adolescent, again, is in the pediatric period, and yung kanyang psychologic task is not on child rearing and childbearing. Nagkakaroon pa lang siya ng identity, no? And hindi niya pa task sa edad ng adolescent, which is around 12 to 18 years old, yung pagkakaroon ng anak. With adolescent pregnancy, nagkakaroon ng higher risk sa pregnancy, labor, delivery, and postpartum. And that includes hypertension and eclampsia, basically because bata pa sila, mas nagkakaroon ng risk dun sa vasospasm sa kanilang circulatory system. Anemia, mainly dahil yung kakulangan ng blood, no? Ang batang adolescent halos kakaumpisa pa lang magkaroon ng menstruation. Tapos isinabay yung pagbubuntis niya na nagre-require ng increased blood volume. There could also be a difficult labor and childbirth as a result of cephalopelvic disproportion or CPD. Dahil nga siya ay adolescent pa lang, hindi pa ganun ka-well-developed yung paglaki ng size ng pelvic bone niya. Therefore, yung baby ay posibleng hindi magkasya sa pelvic bone, no? And that would warrant a cesarean section, kaya hindi possible ang vaginal birth. There's also increased maternal mortality because of all the heavy tasks ng lahat ng organs ng katawan. When a woman is pregnant, when a woman is delivering a baby, and postpartum as well. And again, hindi pa ganun ka-mature ang organs ng isang adolescent to be able to carry all those burden. And lastly, low birth weight because of the risks doon sa nutritional condition, no? Yung nutritional deprivation dahil nga sabay na nagde-develop yung fetus sa loob ng uterus and the adolescent who is also still developing. Now, it's important that we teach these mothers about adequate prenatal care. Provide nutritional counseling, importante, high iron content, iron supplements, teach them about coping skills, ituro ano ba ang dapat i-anticipate during labor and delivery, and of course, be ready for child care skills. Paano magpaligo ng bata, the immunizations, and other details necessary, how to be a mother, no, during the child rearing process. The last of my slides is on prenatal substance abuse. Commonly abused substances during pregnancy is alcohol, cocaine, and the opiates. Sa alcohol, now remember that this always crosses the placenta. Unlike HIV I mentioned before, buti pa yung HIV may mga pagkakataon na hindi nagko-cross ng placenta. Kaya safe si baby, but alcohol always crosses the placenta. Alcohol is good for the heart at moderate amounts. But if a woman is pregnant, no level of alcohol will give a benefit to both the mother and the baby. Okay, mainly because when you receive alcohol in your body, it goes to your nervous system and it depresses the nervous system. No? Now, sa fetus, in effect, no, yung nervous system din niya yung affected. It can cause intrauterine growth retardation, CNS dysfunction, paglabas ng baby, nagkakaroon siya ng tremors, baka magkaroon siya ng seizures, no? So magre-require siya ng mga matatapang na gamot to manage that. And even craniofacial abnormalities or what we call the fetal alcohol syndrome. Yung cocaine o yung mga shabu or other drugs, it's a very powerful stimulant, very addictive. No? This causes severe vasoconstriction, seizures, and oxygen problems. Kung si mommy ay addict dito, addict na rin yung baby. So again, maraming affected sa kanya. Multi-system. One is yung nervous system, no? Irritability, hypertonicity, yung neuromuscular system, poor feeding patterns, and nag-i-increase yung risk ng sudden infant death syndrome. Yung neonate o yung infant, namamatay sila quietly in their sleep without seeing any obvious or valid reason bakit sila namamatay. Third are the opiates. No? They produce analgesia, euphoria, and respiratory depression. Kung sa baby naman, nagkakaroon din sila ng mga problems. No? High-pitched cry, ang tining-tining nung iyak ng mga baby na yan. They are very restless, so neuromuscular irritability also, and poor feeding, which causes problems in the nutrition. So that's it. Thank you very much. Those are our lessons in pregnancy complications.